if somebody calls, right, your toll-free number, and somebody answers, hello, I mean, like instantly you're like, am I speaking with,
Yeah.
immediately trust is broken. Or they pick up and they sound like they're sleeping.
Yeah.
And we're human, right?
Hello, healthcare enthusiasts, and welcome back to The Cure. This is the podcast where we're revolutionizing the business of healthcare in Africa, one conversation at a time. I'm your host, Tim Topekoka, and in every episode, I sit down with the people that are shaping the future of healthcare on the continent, from founders to investors to policymakers and beyond. And our goal is very simple: to infuse hope back into the narrative by spotlighting the progress and momentum that is already unfolding across the continent. At the heart of every episode is one key question: what does it take to revolutionize the African healthcare business model? All our insights are powered by TC Health, your trusted source for healthcare and pharmaceutical insights in sub-Saharan Africa. So let's get into today's episode. In season 2, we're exploring what it takes to build the rails. And by rails, we mean the regulation, the financing, the infrastructure, the partnerships that turn a promising idea into reliable care at scale. Today's conversation sits at the very edge of that theme, where the absence of those rails is the most visible and the most fatal. I'll paint a picture that most of you will be very familiar with. Late last year, a Lexus SUV traveling along the Lagos-Ibadan Expressway burst a tire and collided with a stationary truck near Danko. 2 of the passengers died at the scene. The most famous one survived. The world watched as bystanders pulled him from the wreckage with no spinal precautions, no triage, no awareness of pre-hospital protocols, and drove him from the scene in another private car. There were no ambulances on site. There was no command center coordinating the response. Lagos State would later confirm that ambulances were dispatched, but after the fact. If the man in that vehicle had not been Anthony Joshua, the story would not have traveled. But that is the experience of every Nigerian who has had an accident, not just on that road, but on countless roads across the country. The cameras simply were just not rolling. Emergency response is the stress test for every other rail in a health system. It tells you whether financing covers that specific moment when a patient cannot shop around. It tells you whether public and private actors can move in real time and work together rather than moving at the speed of an MOU. It tells you whether data flows between the first responders, the paramedics, and the hospitals. And it tells you whether the public trusts the formal system enough to call it. If you can build the rails for emergency response, the same rails will carry maternal care, the same rails will carry road safety, the same rails will carry chronic disease management, the same rails will carry primary care referral. If you can't build those rails, then every other reform kind of sits on sand. And my guest today has spent the past 7 years building those rails. Folake Owodunni is the co-founder and CEO of Emergency Response Africa, a health tech company transforming how medical emergencies are managed across the continent, beginning in Nigeria. ERA operates the largest network of community first responders, ambulances, and verified emergency-ready hospitals in the country, connecting them through a proprietary dispatch platform and a 24/7 command center. Since its launch, ERA has managed over 4,500 medical emergencies, reduced response times by up to 80%, and built state-level partnerships with governments across multiple states. Folake holds an MSc in Global Health and Development from University College London, a Master's in Business Entrepreneurship and Technology from the University of Waterloo, and is herself a certified first responder with the Canadian Red Cross. She is the 2024 Aurora Tech Award award winner, a Google Black Founders Fund recipient, a Rainer Arnold Fellow with the Mulago Foundation, and a Women Lift Health Leadership Fellow. And Folake and I have history. So back in 2022, we co-authored a TC Health piece titled Emergency Medical Services in Nigeria, First Response No Longer a Last Resort. To date, it's one of our most read articles on the website. And that article diagnosed a system in crisis. And today, 4 years on, we're sitting down to ask what has actually changed, what hasn't changed, and what it takes to make sure the next call for help in Nigeria is answered. So, Folake, welcome to The Cure.
Thank you. Good to be here. And good to see you.
I know. We've been planning a coffee for like
it will still
6
happen.
months. This is a pseudo coffee, but the real coffee is coming.
There's mugs.
Yeah, there's mugs. Whether there's coffee in them is questionable, but we'll have our real coffee soon.
Deal.
So before we get into our conversation, I want to take a few minutes to set the stage on the state of emergency medical services in Nigeria today. And I really invite you to join me just to talk about what has shifted since the 2022 article that we wrote and where some of those gaps remain. So I want to start with, the cost of the gap. Before we get to where we are today, I want to look at the picture as it stood in 2022, because I went back and read our article. And when we first wrote about this, we looked into studies of major urban hospitals in Nigeria that found that up to 75% of emergency patients were either dead on arrival or died within 6 hours of arrival at the hospital, driven primarily by poor pre-hospital infrastructure and inadequate transportation to the hospital. We also looked at pediatric emergency departments, showed the same pattern. So most of the deaths occurring among patients who reported late with limited pre-hospital care. In 2019, ERA, Emergency Response Africa, did a national survey that showed that 3 out of 4 Nigerians had experienced at least one medical emergency in the past 5 years, and over a quarter had experienced more than 4 medical emergencies. And it ranged from acute chronic medical conditions and road traffic accidents as driving like the bulk of those emergencies. And when we looked at the wider sub-Saharan African picture in that paper, it wasn't that much better than Nigeria.
Yep.
So there was a World Bank study at the time that found that very few sub-Saharan African countries had developed a systematic or financially sustainable approach to emergency medical services at scale. Lagos State, the country's best funded system, if we're being real, recorded ambulance response times ranging from 7 to 60 minutes, which is more than double the median urban response time in the United States. And then on the demand side, the picture was bleakest of all. So in that same ERA survey in 2019, only 3% of respondents reported calling an emergency number for ambulance service as the first step taken when they needed help in an emergency. 3%. 78% called family or friends, drove, borrowed, or hired a vehicle. And once they reached the hospital, 44% were rejected, had treatment delayed, or were referred elsewhere without any treatment, which led to about 64% reporting significant dissatisfaction with how the emergency was managed. And I remember looking through, because when we wrote the piece together, you shared the survey results with me, and I was shocked, but I also had to question, if I was in an emergency today, what, as a Nigerian, what's my first instinct? Like, what's the first instinct of anyone in an emergency? And I'm so curious we'll get into it, but I would love to hear, like, how do you think these numbers have evolved since 2019, about 7 years ago, to where we stand today?
So, I mean, a quick fun story to tell you kind of how we think. A couple years ago, my dad, I guess fell. I can't remember where he was, but he fell and hurt his ankle. Now, it's not life-threatening, right? So, one could argue, is this really an emergency? But his instinct and what he did was to still somehow get in his car and drive himself to the hospital. He didn't even call to say, oh, this happened, come and help me,
Yeah.
And, I remember being like, wow, if my own father takes that approach, what hope is there? It's so ingrained in us. And if you think about it from the lens of, as a people, we have had to do so much for ourselves.
Yeah.
Whether it's power or water or building our own houses or manufacturing our own whatever it is. We're so used to that we really don't rely on the systems that are available because we've learned that those systems can't be trusted.
Yeah.
So to your question, how have those numbers changed? I'm an optimist, especially when it comes
Love
to
it.
healthcare.
Yeah.
So I would say that I'm sure they've changed, right? And I'm sure we'll get into this, but
Yeah.
I'll use one of the programs that we did in partnership with the state government. And, one of the outputs of that in our report was that about 12% of people that were coming to the hospital had come in an ambulance.
Okay, 3 to
Now,
12%.
exactly. Now, but again, right, we're not talking like super empirical, very robust, evidence. We're talking a pilot in a particular location, very sort of contained environment, but still, right? I choose hope because that tells me that, okay, if you actually intervene, if you provide the service and if you intentionally communicate and if you remove the barriers that usually stand in the way, you'll see people actually use it. You'll see a change in behavior. So to your question, has it changed? I think we're making progress. Does anybody really, really have the data to show?
Yeah.
I don't think so.
Yeah. And that reminds me of a conversation that we had with Dr. Nato last season, where he was like, he mentors a lot of students who always want to do a literature review, but he's like, no, do it
Go and collect
original,
data.
go and collect
Absolutely.
the data, because that's what we need. And we need people to chronicle the data, especially in this space, just to kind of, we have half a picture, if even that, of what it actually looks like for the average Nigerian in an emergency.
Yeah. I will say, like, Neto is one of the special people that is an effective doer in terms of, entrepreneurship, and is also the researcher, the thinker, able to articulate that. Not many of us can do that. And one thing I believe we need more of, and I don't want to like detour too much, is just collaboration between academia and entrepreneurs. The reality is, I want to do this work. I want to implement. I want to, go into a space and create a system and run that system and deliver results. But there are academics who are skilled at collecting the data and making sure that what we're doing is actually having the desired effect. I think what's missing or what there just isn't enough of is the collaboration that actually allows the work that's being done to translate into evidence that can be used to inform other work and improve the work over time. So, I mean, Anyway.
No, and the studies that we use are all academic studies, like the studies of major urban areas and hospitals. Like that was done in academia. So I completely agree. But let's look at where things stand closer to 2026. The Federal Road Safety Corps reported 5,421 road traffic deaths in Nigeria in 2024, a 7% increase from 5,081 the year before. In 2025, 10,446 crashes were recorded, with 33,400 people injured. And behind, because, I could estimate these numbers and say, about 33,000, but behind every one of these numbers is a person in distress, a family in distress, a window of minutes. And that window determines whether someone walks away or does not walk away from an accident. And I think all too often we see people not walking away, not because of the accident itself, but because of how they what happens after. Maternal and child mortality also tell a similar story, because it is an emergency. Obstetric emergencies are one of the most common emergencies, and I think a very important type of emergency, especially when we look at Nigeria's stats. The 2024 Nigeria Demographic and Health Survey showed that a Nigerian woman faces a 1 in 19 lifetime risk of dying during pregnancy or childbirth, compared with a 1 in 4,900 risk in high-income countries. I think it's crazy. I had to
How
when
do
I
you
was
wrap your
Googling
mind
it, I had to
around
check.
19 versus 4,000? Yeah, it's crazy.
It's I even tried to do the mental math. Let's round up 4,900 to 5,000.
Yeah.
19 to 20. I can't do the mental math if you divide those, but it's like 100-fold risk of dying in pregnancy or childbirth. Only 46% of births are attended by a skilled healthcare worker. Nigeria still accounts for nearly 20% of global maternal deaths. Again,
we're the largest contributor now.
Yeah.
It wasn't us a few years ago, but now it's up.
How have we gotten worse? And
Yeah.
when I see this 20%, I'm like, okay, so 20% of all the women in the world who die during childbirth or pregnancy.
Yeah. And what percentage of all the women in the world are Nigerian? It's not 20%.
Yeah, it's not 20%.
Yeah.
So one in every 5 women who die during childbirth or pregnancy is Nigerian.
Yeah. It's crazy.
So sometimes I wrote a piece way back in the day on maternal mortality in Nigeria, and I thought, okay, looking back at that piece and then today, things would have changed. I know there's some initiatives we'll talk about, like SEMONC by the National Health Insurance Agency, but the numbers are staggering.
Yeah.
And I know one of your collaborations with state governments in Ogun State is in that vertical for maternal.
That, absolutely.
So I can't wait to unpack that because it's very striking.
Yeah.
The most rigorous data we have post NEMSAS, the National Emergency Medical Service and Ambulance System, on actual usage comes from a 2023 cross-sectional study, which surveyed about 1,177 residents of the Federal Capital Territories in Abuja. In 93% of emergency cases, no call was made to EMS, emergency medical services at all. 93%. Ambulances were used to transport patients in only 1.8% of cases.
Yeah.
Private or public transport was used in 95% of cases. Where an ambulance was called and arrived, the mean arrival time was 25.6 minutes, almost half an hour. Those numbers are, to me, it shows the massive gap in this subsector of healthcare to really not only make a difference, but honestly to scale a business model.
Yeah.
If 1.8% of people call an ambulance today, and 95% use either private or public. Imagine being in an emergency and you go on public transport to get to the hospital. That gap is huge.
Yeah. And who's going to build a business off of that? Where's the demand?
Yeah.
We've not even talked about what proportion of the 1.8% that call can afford to pay when it is a paid service. Because let's also remember that what the government can provide free of charge is incredibly limited. And as with everything in the healthcare sector, the majority of service delivery ultimately gets provided by the private sector. So there's that number, that 1.8 is still probably, closer to 5, say, I'm calling a random number, but it just tells you that there is a big gap for sure. There is, and the opportunity is also huge. But the effort that it will take to get there
is huge. And most of these deaths are not caused by the medical event itself. They are caused by the gap that between the event and the hospital. Global research suggests that if functioning pre-hospital emergency system can reduce the risk of premature death by up to 25%. And to me, that is like the single highest leverage intervention that we're not making.
Interesting. There's one study that I saw, and I think this looked at both pre-hospital and the hospital level intervention. Don't quote me, I can't remember for sure. But it actually said that up to 54% of deaths could be prevented with access to timely emergency. Okay. So if you think about the scale of that, right? In Nigeria, every year, over 2 million people are dying in different types of situations. So if you think about what that means, that tells you that if we had a strong, functioning emergency response system end to end, you could potentially cut those numbers in half. That's
Over 1 million
that's
lives
crazy.
saved, yeah.
And when you think about, some of the other interventions that are really meaningful in terms of saving lives, things like vaccines,
Yeah.
those types of, like, this is close to
It's
that.
on par.
But
Yeah,
it's on par.
Yeah,
Absolutely.
yeah.
So again, for me, I say that, emergency care and emergency response is that part of the healthcare sector that nobody really thinks actively about until something has happened.
Yes.
And then when something happens, you're like, oh, wow, there's a big gap here.
Yeah.
Okay, let's try to fix it. But because emergencies, is you as one individual, you're not having an emergency, even if you have a chronic condition, maybe a few times a year.
Yeah.
But no individual truly is having an emergency every time. So it's one of those things that isn't top of mind
Yeah.
daily, both at an individual level as well as a systems level.
Yeah.
And I think that's the first thing that we need to fix. Like, we need to fundamentally focus on it and recognize, like you said, the connection between having that system and what it does for maternal health, what it does for chronic disease management, what it does for just every other part of the healthcare system.
Yeah. And I think emergency medical response or systems it's like the great equalizer, because no matter where you sit on the income spectrum,
Absolutely.
no matter where you are in the country, once you have an emergency, you can't fly yourself out in that very moment. God forbid.
And even if you are holding 10 million naira in your hand
right
as
there,
you are having the emergency,
it can't save you.
Someone might just take the money and run. Like
it cannot
save you. The system is not there. The system is not there.
Yeah,
absolutely.
So to me, it's like it touches everyone equally. But let's talk about what has shifted since 2022. When we wrote that 2022 article, the Federal Ministry of Health had only just recently signed the MOU that operationalized NEMSAS, the National Emergency Medical Service and Ambulance System. 4 years on, NEMSAS-supported structures exist in all 36 states and the Federal Capital Territory. And they have established state emergency medical service and ambulance systems, 21 of those state systems that are fully operational. The toll-free number 112 is now live as a national emergency line for the first time. And I wanted to pause and emphasize that if there's nothing else you take from this episode, 112, everyone should have that number memorized. I'm even talking to the whole production team. I'm talking to everybody watching and listening. If you are in Nigeria, 112, just in the same way 911 or 999 in the UK.
We know everybody else's
emergency number. If they ask you what's the emergency number for Nigeria, what will you say? 112. So if there's nothing, even if you pause the episode right now and you never come back, 112 is what you should remember. No, but don't pause it, because we have a lot of amazing things to say. But yeah, free emergency medical services are available across 30 states. And we've seen a 304% rise in emergency transport beneficiaries year on year, from less than 3,000 to over 11,000. Obviously, in a country of over 200 million people, maybe over 220 million people, 11,000 is
peanuts, but that's okay.
But progress, momentum. I also want to talk about the NHIA that has launched a dedicated comprehensive emergency obstetric and newborn care program, or CEMONC. I've never heard it been said out loud. I always read articles about it. Is it CEMONC or CEMONC?
I feel like I've heard it said CEMONC.
CEMONC?
Yeah.
Okay, CEMONC.
Yeah,
also remember CEMONC. As of late 2025, more than 11,200 women with obstetric emergencies had been successfully managed at NHIA-endorsed CEMONC facilities. And this is the first time a federal financing rail has been built specifically to cover emergency obstetric services, even if it has not been extended to general pre-hospital care. But this, I do feel like spotlighting the progress that has been made by the NHIA with this specific program is very, very important.
Yep.
The National Health Insurance Authority Act of May 2022, also something that happened while or very soon after we were writing this. That was a very
timely.
It was very timely. You know how people say, oh, this is timely, but that was a very timely piece. It made health insurance mandatory for all Nigerians and legal residents, creating the legal foundation for a financing rail that pre-hospital care can eventually plug into. And I think we were just discussing this before we started recording, of how the Basic Healthcare Provision Fund, the BHCPF, is the umbrella that provides care. The NHIA is the delivery mechanism under that umbrella.
One of the gateways
under that mechanism.
Yeah. As is NEMSAS, another one.
And NEMSAS.
The NCDC is another one. So,
okay.
yeah.
So we have the BHCPF. Maybe we'll draw a nice picture. Umbrella. We have NEMSAS, which covers the care from the emergency to you reach the hospital. We have the NHIA that covers the care once you get to the hospital. We have NCDC.
I think there's still some working or adjustment happening there. So.
But on paper or in ideally, that's what the system is. And then the NCDC that responds to kind of
public health,
epidemics, pandemics, public health emergencies. So we have rails, guys. They just need to be further developed and further built. What has still not shifted? Nigeria has roughly 0.4 ambulances per 100,000 people. I think the number was about 500 ambulances across the country, roughly-ish, ballpark. But for, again, a population of 200 plus million. Nobody ever knows the exact. It's over 200 million, likely over 220 million. That is a very small number. The WHO recommends 1 per 10,000 people.
So I think for lower middle income countries, they recommend about 1 per 50,000.
Okay.
You'll see some numbers that even go to 1 to 100,000. I guess that's being like, let's allow for
some progress.
But I think if you take Nigeria's number and kind of, best estimates, our ratio is more like 1 to 250,000 people. So even at it's still we're way off, where we need to be, right? And that's just talking about the ambulances. Yeah, it doesn't talk about the system, the communications, the personnel, all the things that actually make a system work. So yeah.
And just yesterday, President Bola Ahmed Tinubu, so on the 29th of May 2026, for everyone who is probably listening to this episode after the fact, launched 145 tricycle ambulances aimed at improving emergency health services across the country. I think it's important to expand our ambulance structure. So things are happening, but that gap of real ambulances, fully fitted ambulances that can effectively respond to the type of emergencies we see, especially on our roads, that gap is still there.
Yep.
And in our 2022 article, we argued that communication was the binding constraint. So care seekers did not know who to call. The responders, the first responders, the paramedics could not reach the receiving hospitals. The hospitals could not prepare for inbound patients. They didn't know who was coming in. You show up and they're like, okay, let's figure this out. Or they say no and they reject patients. The 2023 data suggests that constraints has loosened in places because now we have 112. But there's still a lot to be done. And I wanted to spend some time talking about why this is a Build the Rails episode, because our season 2 theme is building the rails. And for me, emergency medical services are a crucial rail in any healthcare system. Emergency medical services existed in Nigeria long before ERA. Lagos State established LASAM Bus in 2001. Federal Road Safety operates a fleet of vehicles. Even faith-based hospitals run their own informal transport networks. The challenge is not that the category didn't really exist. I think it's that the challenge is that it has been fragmented. Fragmentation is a word, I think, in the DHN WhatsApp group. Was it last week or this week? Fragmentation. Every problem can be boiled down to fragmentation. It's concentrated in Lagos, a lot of the infrastructure of emergency response. And so the rails are there, but they're not enough to allow it to function as a coordinated service and scale across the country. And so ERA's work and the work that's being done alongside it by NEMSAS, by state governments, by funders, is the closest the country has come to actually consistently building those rails. And that's exactly what our conversation today is about. So I want to start with you.
Okay.
Before we go into, deep diving what it actually takes to build a dependable emergency response system, I do want to start with your background, your backstory. You trained as a global health professional at UCL. You built a career in communications and change management at OpenText and at the University of Waterloo before stepping into health tech. And I would love you to take us back. What was that moment where this work stopped being like an idea and it was like, okay, I have to actually build it?
Good question. So like you said, I was working in communications in a tech company. At the same time, I was completing a second master's program in entrepreneurship at a university that has a fantastic reputation for its School of Engineering and, technology. So in some ways, I was very surrounded by technology. And I think in the context of that program, I'd always had it in the back of my mind that I want to do something in healthcare. I want to solve a meaningful problem in healthcare. And because I had had the experience of calling 911 for my son, this happened 2017, it was one of those experiences that stays with you, right? That sense of, I could call 911 because I'm in Canada.
Yes.
And they picked up the phone. The paramedics showed up. They came with all their equipment. They attended to him. But I think the part that struck me the most was it turned out to be minor, like non-life threatening. And it was resolved there in the living room of my apartment. And what they said to me was, listen, you could come in the ambulance and go with us to the ER and probably end up spending a few hours waiting because that's one of the unfortunate realities.
Yeah.
Or you could, do X, Y, and Z and, in the morning go see your doctor. And I think what that opened my eyes to see was if it was life-threatening, he would have been okay because the intervention was there and it was timely. Because it's non-life-threatening, he's still okay, but also I don't have to go and clog up other parts of the healthcare system. And so I can attend to him in a different way. He gets what he needs right now, and then we get into, primary healthcare, as needed.
Yeah.
And so I think that experience was really very eye-opening. And so when I started to think about, okay, I know I want to do something in healthcare. I want to, solve a tangible problem. That kept coming back to me because I knew that if the same situation had happened in Nigeria, first of all, I wouldn't even know who to call.
Yeah.
Then, my husband and I lived in this apartment building where all the cars would park. And so I, imagine myself going to knock on my neighbor's door, please come and move your car so that we can go to the, and this is something we can all relate with, and then I'm thinking, okay, the hospital that's closest to our estate, they have a very bad reputation. They say if you enter alive, you don't come out alive. So do I really want to take my child there? Or maybe I should go somewhere else. But what if the journey is long or they say they can't? So thinking through all that could have happened made it clear that there was something. There was an opportunity. Interestingly, one of the first people that I spoke to was Dr. Ola Brown, Flying Doctors, and Health Cap, who's actually one of our investors now. But I remember, having a conversation with her, and she was very, very candid. She was like, look, this is a massive problem. There's a massive need, but a really tiny market. And the reason that she had been so successful providing, air ambulance services was because she found the lucrative within that really tiny market and served them. I was talking about, I want to do what will serve everybody. I want, whether you can afford it or you cannot afford it, and that, I think that decision, that approach meant that I was going to have a very long, difficult journey.
Yeah.
And so to an extent, I had a sense of what I was signing up for.
Okay.
But I'm not sure that I fully knew. Right? if you know the whole picture, you don't go in necessarily.
Yeah, exactly.
But I think what then made it clear that, okay, this is not just an idea now, is that my co-founder and I got someone to listen to us and say, I like what you guys are doing. Here's some money. And I'm like, okay, well, they've given us the money. Now we have to do the work.
Starts, yeah.
But I think because of the context in which we were in that university, there were a lot of pitch competitions, those types of opportunities.
Yeah.
And I didn't honestly go in pitching because I wanted someone to give me money. Like I said, when they said they were going to give me money, I was surprised.
Yeah.
It was more so there's this thing and there's this problem and there's this solution that we think can solve the problem. Does it hold weight? Is it valid?
Yeah.
And so it's almost like going out and looking for validation that is there really something here? And so when, we had a few, this is great.
Yeah.
We think this is going to be a very meaningful opportunity. Go and figure out, what the next step is. Here's, I don't know, 20K or whatever. Then it was like, okay, we have to actually do some work.
Yeah.
So,
I'm so curious how because you mentioned your conversation with Dr. Ola Brown, who we are trying to get on this show. She's a very hard woman
busy.
To nail down, but this is me officially shooting my shot.
There you go.
But your conversation with her, where she mentioned, okay, this is how I made it work, but it's actually a very tiny market. How did that transition to her Health Cap Africa now being one of your investors? Like, what shifted in what you were able to kind of show, or the different perspective that you were able to provide, or even data that you were able to show from your initial years to then convert her from a skeptic to an investor?
I mean, I can't speak for her. I don't know, all that she thought. But I think that, better than probably any other investor at the time, she understood what the need was, and that, if somehow it could be cracked business model wise, then there's huge potential.
Yeah.
And so, the question was, is it going to be us? Is it going to be somebody else? Is it going to be now? Is it going to be later? I think those are the questions that every investor is trying to answer. And effectively, they're taking a bet, right? So the way I see it, she cannot have known what will happen 2 years, 3 years down the line.
Yeah.
But I assume that she looked at what we were doing and said, okay, these people seem serious. They seem like, they are determined. Whether I know how hard the market is, but maybe there's something they can do. So, I mean, when you have her, I'll say when, because I believe it will happen. When you have her on, you can ask.
Yeah.
Maybe she'll shed more light, but...
It's also interesting to have an investor who's played in the space, So I think there's some of that kind of interplays. My next question is, you got Red Cross First Responder certified yourself. Why was it important for you to put your own hands on the work before designing the company around emergency medical services?
So I think there were two reasons. One was I'm not a clinician. So I studied public health. I love, thinking in systems and thinking about all the intersections between things. But I don't treat patients, right? I don't intervene if something is happening. Like, everybody around me, don't collapse. I mean, sure, I can do CPR. But you know what I mean, right? Like, I'm not hands-on with patients. And I think that when I thought about what it was that we were trying to build, I felt like, who are you to, try to create something where you're not even, in quote, the one doing that. Now, in hindsight, I think it's just a mindset thing.
Yeah.
I don't believe you have to, in quote, be the technical whatever you're trying to set up. I think there are two different skill sets. I think there's a lot of value and insight that you gain from being hands-on that, you can't replicate by taking a course.
Yeah.
But I also did not, and maybe this is just me personally, I don't like to go into things without feeling like I have some form of insight and some capacity to grasp the experience of the people that are going to be doing the work.
Yeah.
And so, even now, the truth is, I mean, again, I'm not the one riding in the ambulance. Our team does that and they're amazing, truly, truly amazing. I could not do what they do.
Yeah.
Right. But I also felt like I don't want to be so far removed from how they have to do their work.
Yeah.
How do I support them? How do I make sure that we're creating an organization that actually meets their needs and enables them to do their best work? So I think that was really the driver for that.
Yeah. Love that. And then one last personal question before we get into, the system
Other
as a
stuff.
whole. You've described yourself publicly as a faith-driven entrepreneur. What does that actually mean inside a company where every operational decision is actually life or death? And how has it shaped the way you raise capital, the way you lead your team, the way you show up as a founder? I'm very curious.
Yeah. So I don't look at what we do and think, oh my gosh, everything is life or death. It is. But the reality is emergencies will always happen.
Yeah.
Not every death is preventable, right? What is our job? Our job is to be there and give each and every emergency patient their best possible chance of survival. And I think because that is the goal, that is the mindset, how we translate that is one of our values, excellence, right?
Yeah.
So that means arriving on time. It means having all the equipment we're supposed to have.
Yeah.
It means being well trained. It means showing empathy, because sometimes it's not just the clinical work. It's helping people understand that, yes, this is a vulnerable time for you, but we're here.
Yeah.
So you can breathe, you can breathe easier.
Yeah.
So I think first thing is really just, we don't control life and death. That's part of being a faith-driven entrepreneur.
Yeah.
100%, God is in control.
Yeah.
But He has given us the opportunity, the mission to be a part of contributing to life. And so how do we do that excellently? I think the second thing when it comes to being a faith-driven entrepreneur is I've had to learn how to take steps when there's uncertainty. And I mean, they say kind of entrepreneurial personalities, the Richard Bransons of the world, wild and free, or whatever, wild. That is not me. I like to think through things. I like to, sort of explore all the angles and critique. And the downside of that can be very useful, especially in an area where you are dealing with people's lives.
Yeah.
But the downside is paralysis can happen very, very easily.
Analysis
We don't have enough information. We can't do anything.
Yeah.
No, that doesn't work in entrepreneurship, right? So I think that the faith side of it has really, really, really taught me and forced me to be able to recognize when fear is the driving force and put it in the right place.
Yeah.
So fear is an indicator. It's an indicator that maybe I don't have all the information, or it's an indicator that, maybe there's, something that needs to be addressed. But it is that's all it is. It's an indicator. It cannot be in the driving seat. I cannot be led by it. So I think for me, being a faith-driven entrepreneur has really meant okay, I can take a step.
Yeah.
I can take a risk. I can, know what I know and know what I don't know, and be at peace that, this is part of the journey of entrepreneurship. And I've had the opportunity to connect with other entrepreneurs that are in that, faith-driven movement. I know I've even done an interview. There's this faith-driven investor movement. It's been quite good to make those connections. I don't know that I've necessarily had a faith-driven investor approach or anything like that.
Yeah.
But personally, certainly as an entrepreneur, as a leader, how I show up for my team. I mean, you can talk to my team. Every opportunity I get, I don't demean. I'm very intentional about the culture that we have. Let it be a place where people can come to work and they can be okay at work. They know that they're contributing to something meaningful, and that will be recognized. So,
yeah, I love that. I love what you said specifically about fear. I think it's something a lot of entrepreneurs, and even people who maybe feel like they're maybe in an industry that they're not as imposter syndrome, etc. I think fear comes up a lot. I was reading a devotional the other day, and it said fear is the result of the human capacity to apply our knowledge into the future. So without our capacity to fear, if you willed your fear away, you would also will your hope away. Because it's on a spectrum. Hope allows you to apply your knowledge into the future that things could actually look good. And you said you're an optimist. The flip side is fear. And I think a lot of the times we want it as like fear should just disappear. But your hope would disappear as well. So
I think
really
recognizing that there is a purpose to fear and it is an indicator of something has really helped. Like just don't see it as it's not a bad thing. It is part of the human condition, like you've said.
Yeah. So I wanted to use our 2022 article as a deliberate scorecard for this episode. We made 3 big arguments in that piece, and I want to walk through each of those and kind of test each one against like what you've seen in the actual field in the last 4 years. So the first argument was diagnostic. We said pre-hospital mortality was driven by the absence of trained responders, working ambulances, and a clear pathway to a receiving hospital. 4 years later, do you think this diagnosis still holds, or where have things changed? You know, we saw that 93% stat of emergency cases never resulted in an EMS call versus the 1.8% stat that we now know could even be smaller. Does that match what ERA sees in the field today?
Absolutely. I think it's... In that regard, I wouldn't say very much has changed. We still only have one accredited institution training paramedics. We have some other schools, like usually like some schools of technology that are training, you know, in quote, EMTs, paramedics. But we've seen that the quality is different, right? So that's very much still a gap. I would argue that the number of ambulances has even shrunk. Because whereas 4 years ago, it seemed to be easier to identify and, you know, assess and onboard ambulances to our network, that has gotten much, much harder, especially in the last 2 years. And it's not that surprising, right? When you think about what has happened with the economy, how much more expensive it's gotten to operate a vehicle. And when you think about the issue around the demand or the missing demand, and now I'm talking about the paid demand, for a lot of partners or hospitals or individuals that own ambulances, you start to ask yourself a question, is this a worthwhile investment, right? Because if I have the vehicle, but I'm not using it to transport patients, or I'm only using it for a few patients, and I cannot run it profitably, then why do I have it? Which means that the day that it breaks down and you need to replace the axle for, you know, I don't know, 1 million naira, you're going to be asking yourself, how much does this thing even make for me on a normal day, right? And so we've seen a number of partners who had ambulances and have kind of set them aside. Not because there isn't a need for them, but because the market part of it, the demand part of it, the ability to sustain it has become much, much more difficult. And then I think the communication challenge remains. On the one hand, right, mobile penetration has gone up. Access to internet has also gone up. You know, more than ever, people are connected. But communication is also about awareness, right? So you were saying earlier, 112, people should know the number, people should know the number. True, absolutely. A lot of people don't know the number. But part of it is also trust, right? So you have situations where people will call and they will get what they need. But there are equally as many situations where people will call and not get what they need. And so because of the lack of trust, even the instinct to call has not taken root. And so has anything changed in that regard? I would say no. I don't think we've seen significant improvement across those areas. There's still a lot of work to do, for sure.
I think that point around trust is so important to everything we're discussing today, because you can get 100,000 ambulances, you can, you know, get more tricycle ambulances, air ambulances, but when you dial 112, do you trust that someone is coming? Because if I'm in the US or if I'm in the UK and I dial 911 or 999, I instinctively trust or intuitively trust that someone is going to show up.
Yeah. If they're
in
late,
the
you'll be
next few minutes.
surprised.
Yeah, be like,
because
it's taking like 15 minutes, 10 minutes. But I trust the outcome of that interaction. And I think that gap between where we are now and getting to that level of trust is, you can't like supersede, or what's the word?
You can't leap.
You can't leap through that gap. That gap is built by every single call that is answered consistently, and someone can tell a story.
But here's part of, I totally agree, right? Being able to tell that story, because that's what people will refer, right?
Yeah.
I called 112 and they answered. Oh, yes, I know the answer. Really? Okay, okay, next time, right? Those things make a difference.
Yeah.
But and this is why I love systems, right? Because you have to see all the connections.
Yeah.
When we talk about capacity building and the trained responders, it's very easy for us to think about the people that are in the field. What about the people that are answering the calls? Don't forget the 911s and the 999s, they have programs for emergency medical dispatchers.
Yeah.
These are people who are trained to be able to pick up the phone and triage effectively and provide support, basic first aid over the phone support that, a child who is with a collapsed parent can follow some instructions, that type of thing.
Yeah.
That is a skill set.
Yeah.
And that is a skill set that has to be trained and developed. And I know even for us, we've had to do that in-house.
Yeah.
In other words, I have bought Principles of Emergency Medical Dispatch, that is the textbook, and we have trained ourselves in-house to be able to do that. And we have had the opportunity to start to train others within the public sector to be able to do that. But that's part of the trust building.
Yeah.
Because if somebody calls, right, your toll-free number, and somebody answers, hello, I mean, instantly you're like, am I speaking with,
Yeah.
Immediately trust is broken, or they pick up and they sound like they're sleeping.
Yeah.
And we're human, right? This is where training comes in, and this is where accountability comes in, and this is stuff that we have had to build ourselves and are still build ourselves to do, right?
Yeah.
So just saying that, trust is not just at the level of the response that is happening in that moment. It starts with all of the core systems and people and resources that make it possible for that moment to actually happen seamlessly.
I would like to ask a follow-up question because I'm very curious about the actual training of emergency response dispatchers. You bought that Principles of Emergency
This was like 2021.
Yeah. That, I presume, is an internationally developed guideline.
Yep.
When you said immediately, like if you call and someone is like, hello, my first thought was, I've had really bad customer service experiences in Nigeria. I actually had one like in the last week where I ordered a desk for the space and I got ghosted.
Sorry.
Okay. What have you had to adapt to the local context when you're training an emergency response dispatcher? Like, there is something unique about our culture. Like, if someone elderly calls the line, how do you speak to that person? Because I'm sure in the midst of an emergency, someone will go, I'm not your mate.
Which is totally possible.
Yes, so I'm curious.
So I'm struggling to sort of put my thoughts together, but I'll try to say a couple of things. First is, honestly, we do have amazing people that do the work. Like, we have a small, they say small but mighty team. And our medical dispatchers, I've listened to the calls where, the person calls, they have a standard response. You've reached Emergency Response Africa. What is your emergency? And then instantly, the person on the other end is like, maybe they start speaking Yoruba or they start speaking in Pidgin. And so they instinctively know to adjust their language, to simplify, or if they speak the language, to switch to the local language. And you can instantly hear the change, the warmth from the person that's calling, because it's like, oh, okay, I'm talking to somebody that understands me, and me too, I understand them. That's one. But then the empathy that then they convey, right, also makes a world of difference in terms of how the communication flows.
Yeah.
I think where we are now, like individually and, thinking about how we scale our training is how do you codify those types of things, right? Those things are very human instincts. You have a process, you have a script, you have your, your triage protocol, you have your algorithms, the things that you follow in order to effectively get to the right response. But something comes up and culturally, you can tell that you're talking to an elderly person and that person is terrified. How do you reassure them? How do you treat them like your mother? And this is why, I will always, as much as possible, give credit to my team because we have some truly remarkable testimonials. In fact, one person said that the way that these people treated my mother, it was like it was their own mother. They were just so overjoyed, so happy. And so I think, it's one thing to train on the core skills of how do you triage effectively, what should your script look like, what are the common types of emergencies that you see, and what is the flow as, you kind of find out more information and you progress. It's another thing to take the human side of it and codify that. And I feel like that is actually the phase that we are now. Like empathy is one of our core values as an organization and they do a great job, demonstrating it. But how do you go from, this person does a phenomenal job to it being that consistent experience that we can train other people to do? Because ideally, if you call 112, right, you want to know that the person that's going to pick up, whether it's a Friday at 8:45 p.m. or Tuesday at, right at the beginning of shift, you want to know that you're going to get the same consistent, positive, empathetic experience. And I think that going back to the conversation around trust, that is what's missing. So you might call on Tuesday when the person is fresh, they've just come in, they are ready to take on the world, and they give you a great experience. And then you call them Friday night and they should be at home, but they are here because somebody called them into work, and you get something entirely different. So there's a lot of work to do. I keep saying.
I'm envisioning a future where you develop a adapted guide for Nigeria or West Africa.
Yes, absolutely. Absolutely.
Yeah.
I mean, one of the things that we have started, but I would say on a smaller scale, is just training broadly, right? So capacity building. So we do a lot of first aid training. We're now an American Heart Association accredited training site. So we also provide basic life support certified by AHA. Like I said, we've done, emergency medical dispatch training off of, what we've developed and adapted. And we've also developed a curriculum for community-based first responders, right? So now we're not talking about people who are doing this as professionals. We're talking about anybody like you and I, or, whoever is saying, hey, I want to be a first responder in my community. I want to be able to be that first point of call before an ambulance gets here. Or maybe I live in one of those hard to reach areas and the ambulance is not coming anytime soon, right? So I want to be that first step. So we actually partnered with the University of Benin Teaching Hospital, their paramedic program, and we developed a community-based first responder curriculum. So we've done a lot of great sort of foundational work. Definitely the vision is to really have a full-fledged academy where we can train EMTs, we can train paramedics, we can train dispatchers, even the drivers of ambulances. They need specific training to make sure that they keep the vehicle safe, but most importantly, the patient that is rolling around inside the vehicle is also safe, right? So absolutely. The vision is there.
It's there.
We just need...
We're getting to the vision. So our second argument from the paper was about policy. That NEMSAS MOU had been signed, I think, weeks before we published the piece. The NHIA Act was about a month away after we published. We have the Basic Healthcare Provision Fund that now has the 5% emergency allocation. Walk us through that policy layer. How have you seen those things evolved? How do you see NEMSAS today? Where do you see things need to move forward, and things like that?
So I've always believed that policy isn't our problem. I know for a fact that, there's a lot more to policy than, kind of the normal us that are on the outside of government see. But I do believe that policy isn't our problem. we create things, they may not be perfect, but they are often a good start.
Yeah.
The challenge is often the gap between policy and implementation, right? And sometimes what happens is the policy is not structured in a way that gives it the necessary legs to be able to effectively implement. And I know this from just having engaged quite closely with NEMSAS, especially over the past year.
Yeah.
It is, in principle, an incredible opportunity for Nigeria. And I'm happy to see, a bunch of the work that's been done and the progress that's been made. I'll say very quickly that I think as Nigerians, it's very easy for us to bash our government.
Yeah.
And, sometimes we're justified, but most of the time, we have to recognize that it is really hard to try to turn a ship around, a 220 million, whatever the population is, ship that has been going in one direction for a really long time. So regardless of who you are in leadership, it's not an easy task.
Yeah.
So on the basis of that, I will say that I'm happy to see some of the work that's been done, the initiatives, the efforts, the numbers that have been reported.
Yeah.
At the same time, it's one thing to have NEMSAS. It's another thing for NEMSAS to actually have the authority to do certain things. And if you think about the nature of Nigeria, our federal structure, right? You have the Federal Ministry of Health and Social Welfare that is in charge of certain sort of core national programs.
Yeah.
But at the end of the day, the delivery of healthcare services to the patient happens at a state level and is within very much the control of the state. And so what you have is, unless the federal government has, carrot and stick to effectively corral states to do what they want, implementation will always be, kind of lumpy. And I think that's the reality of healthcare broadly, and it's no different within emergency services. So policy isn't necessarily our problem. I think maybe the only problem I would say with policy is that we don't always do sufficient work of making sure it's rooted in data, right? Going back to the earlier conversation we were having about the need for actual on the ground tangible data. But even when the policy is there, how do you structure it so that the bodies that are responsible for implementing actually have the authority to do it? They have the resources to do it. I mean, if you say you want to change emergency services in a country like Nigeria with 220 million people, you're not going to do it with a small bag of money. Yeah. Right? You're not going to do it with only the public sector. Yeah. Everybody has to be involved, and it has to work in a way that is meaningful for everybody. Yeah. So the work, I think there's efforts being made, and I think it's important that we acknowledge and validate those efforts. At the same time, could things move faster? Could things be more, structured or open or more accessible, especially to the private sector who will continue to deliver the bulk of services? Yeah. For sure. There's a gap there.
Yeah. No, I completely agree. The third argument was about communication. We said the solution had to be a single memorable number. I think that has been done. It had to be location-driven, and that it had to enable real-time data flow between responders and hospitals. I would love you to talk us through the ERA stack. So Emergency Response Africa is a health tech company. Yep. There is technology connecting your first responders to your command center or control center, like your dispatchers, to hospitals that you have kind of pre-accredited or pre-evaluated to be receiving hospitals. Walk us through, take us inside the command center, take us inside the technology stack that you've built and how it, one, operates along this continuum of communication, but just generally, I think our listeners would love to know how it works.
So I'll start with a quick random story. I went to a 911 dispatch center somewhere in Canada, in Ontario, just as part of, familiarizing myself with the space and seeing how...
They let you in? Like you just walk in?
Yeah. No. You can't just walk
you had
in.
to like...
Someone had to take me in.
Okay.
Yeah, so one of our advisors, actually angel investors at the time, had a friend who, was in charge of one of those centers. And so he took us in for a tour. And I remember walking into the command center and thinking, whoa, this is what ours is going to look like. You had the desks, you had the massive screens and things were flashing and people were talking. It was fantastic. So our command center is nothing like that. It is very, very simple. And I think that it reflects our environment.
Yeah.
The reality is, yes, we could go and look for money to get the bells and the whistles.
Yeah.
But it didn't take us long to realize that the problems we're solving are very, very low level, very basic problems. We're trying to coordinate fragmentation, right? And so our command center today, simple room in our office. Yes, you have a few screens. You have the dispatchers and they're seated, picking up the calls. But the way that the system works is designed to connect all the stakeholders as seamlessly as possible.
Yeah.
What that means is we have a toll-free number. Unfortunately, it is not a 3-digit, super
I have it
memorable.
In my script. It's like...
Yeah, it's like 08000 call CALLERA.
Yeah.
So that's like the best you can do as far as like memorizing it. But that's again, right, part of the realities of our environment. Ideally, I shouldn't need to have a number.
Yeah.
If you called 112 or let's say you're in Lagos 767, because ideally we should have a partnership that allows them to say, hey, you guys happen to be the closest to this case, we're going to send it to you, right?
Yeah.
That's the ideal state. And that's what you see in other emergency services. So again, we know we're not in ideal, so we'll keep doing what we're doing. So we do have that toll-free number. But the second way that people can reach us is through APIs. So we have partnerships with insurers, with other organizations who have their own mobile apps.
Okay.
And because of the nature of what they do, they would like to have like an emergency button within their app.
Yeah.
And so we're able to supply APIs that allow them to have an emergency button and basically an emergency request process within their own application. And so their users can, simply push that button and get the help they need without ever having to leave that partner's application, right? So those are really the two core ways that people will reach us today. And so once that comes into our command center, our dispatchers are able to see it on their dispatch application. And it works, I would say, a lot like kind of an Uber, style structure, right? So they go through their triage process, and then the system has algorithms that basically allow it to recommend the appropriate response.
Yeah.
So if somebody is, has suddenly collapsed, and based on the triage process, it's clear that hey, this might be a case of like a sudden cardiac arrest.
Yeah.
You're not trying to send a community first responder in their little vehicle or whatever. What you need is a full-on ambulance with a defibrillator and as quickly as possible. In fact, we have a couple of motorcycle medics that can get there faster with the equipment and start treatment before an ambulance gets there, and that can be useful in a place like Lagos. And so the system is able to basically recommend that appropriate response and send out the details of the case to those that are in the field.
Yeah.
Now they have their own application, very similar again, right? Uber driver application style. They receive the details of the case, they can accept, they can navigate, and when they are done, they can report back.
Yeah.
Right. And that adds, basically creates almost like a full case picture.
Yeah.
Now, what happens if the patient needs to go to the hospital? Because, like you said, we have hospitals that we work with, but also this is Nigeria. A lot of times people either have a hospital that they are already affiliated with, maybe they were already getting treatment, so sometimes they will recommend, and we can refer, to there, and we will notify the hospitals in advance.
Yeah.
I would like to say that, the hospitals are just, they have this dashboard, and I don't like to tell lies. In truth, a lot of times it is actually a manual communication because we have found that most of the time, and I think it's the nature of, the hospital, the front desk, the ER, the way that they work, most of the time, we want to be able to have our system automatically send SMS notifications to the appropriate number and then back it up with a phone call.
Yeah.
So that's kind of what we have. Maybe the last thing I'll say is around when we are working in areas that aren't like, a city center with great internet.
Yeah.
Is there great internet anyway? But anyway, let's just say, right, we're working on the outskirts and the more rural areas, and internet connection is a problem.
Yeah.
We have a USSD system that basically works in parallel and also intersects with our core technology. And what that allows is for us to still be able to coordinate the dispatch and inform. Usually, these are community first responders to say, hey, there's a case happening near you. It's something that we're actually doing right now in Ogun State.
Yeah.
There's a case happening near you, and they get it. They can dial a short code *334#, and they see a menu. View case, accept case, and all they're doing is put in 1, submit, or 2, submit, and that gets communicated. And the value there is that it allows us to still capture what is happening without necessarily the full, sort of internet technology setup. So from a technology stack perspective, it's something that end to end allows us to get a full view on what has happened in the case. And then, of course, be able to tell, like, how did we actually help this patient?
Yeah. I have 2 follow-up questions. One is around the Emergency Ready Hospital Network. The other is around the idea of this USSD SMS layer. Which one do you want me to ask first?
You pick.
Okay, I'll go in order. The Emergency Ready Hospital Network, I think, is doing something a lot of ambulance services have never had to do or have never done, which is verifying that a receiving hospital is actually ready to receive. You talked about it's quite a manual process of calling the hospital and letting them know, hey, there's a case coming in. Before that even happens, what does that verification process look like in practice? So before a hospital is tagged as emergency ready to even receive patients, what has it revealed about, the state of emergency departments in Nigeria? Because they have a really bad rep. I think up until recent policies that made it illegal to turn patients away, a lot of people...
And it still happens,
And it still
happens.
A lot of people are fearful that they show up to an emergency department in a hospital and they're turned away. So why bother going in the first place?
So I think there's 2 sides to every story, right? What we've also seen is the hospital side of it, not in any way saying that it is okay or justified, but we've also come to learn some of the challenges that hospitals face. We will treat out of the duty that we set out, when we entered into this profession, and then encounter multiple challenges, right? It goes back to trust. Let's be honest. Like, it still goes back to trust. If you tell me, go ahead and treat, I'll pay you, but then you don't, or it takes a really, really, really long time, then my incentive is lower the next time a patient comes. And unless it is truly out of the goodness of my heart, there's that reluctance. The other thing is, if you have a struggling economy, if you have a world where a lot of your patients are having to pay out of pocket and healthcare facilities cannot be assured of, certain revenue levels and all that, it is easier for them to cut corners. Again, not in any way justifying, but just recognizing that the realities of our environment and our economy make for certain things, to happen. And so what that translates to is not everywhere that is called a hospital or, an emergency room is going to be able to serve you. And we see that with ambulances. We're always trying to add more to our network. And we'll go and we'll inspect and we'll be like, this is like a bus with a bed. Ooh. And that's kind of it. Like, there's nothing else. And then, but again, I think we've also developed empathy for, the supplier side, because we know what we are up against and, how difficult it is. And so just fundamentally, like, our approach really is to, when we identify, to actually inspect. And an inspection is not like, we're not going to be able to see every nook and cranny, but we want to know certain core things. Do they have the equipment? How do they staff themselves? Who do we call? What's the protocol for bringing a patient to you? Do you use technology in any form? Do you have internet, or are you strictly paper based? Like all of those things speak to how the ER is managed, and what kind of experience any patient we take can expect. And so we have the hospitals that we, kind of say like, okay, in this area, we have this hospital that we've partnered with. And what that partnership simply does is it gives the patient a reasonable level of confidence that you go and you get decent care, but also that the handover process is relatively simple. In other words, we're not going to take you there and then you'll be sitting in the hallway forever, right? Like that's a thing that also happens. But like I said, in Nigeria, we often will have our own, because again, a lot of it's private sector, right? People will have their preferences, people will have the places that they already have a relationship with. And so people will often say like, no, take me to XYZ hospital. Now, what we've learned to do is to be like, okay, so who do you have in XYZ hospital? My uncle is the doctor there, something. Okay. Can we so while we're attending to you and while we're en route, can we call them? Can we connect with them in advance, right? To make sure that when we get there, you can actually be attended to. Because I can tell you till today, we still have patients who will insist on going to one place. We get there, there's no bed space. Whoever was, I guess the person supposed to be advocating for them, I guess can't deliver. And so, okay, now, you wait a couple of hours, now you end up going to another place, then you end up going to another place, and patients deteriorate in that process, right? So it's a persistent issue. Like, yes, we tried to solve it by having this network of hospitals, but the reality is because so many people have their own, places and preferences, and if you're not actively like, if we don't take you here now, you're gonna die. We honor those preferences, but it introduces other challenges.
Interesting. So the trust isn't just if I call, will the ambulance show up? The trust is, where are you going to drop me?
Oh, absolutely.
Like, where are you taking me?
100%. Oh, 100%. If by the time they call, right, there are only two things. One, maybe they genuinely believe that you will show up either because they're referred, or is their healthcare practitioner calling, or they've heard about it, whatever. Or they are that desperate that they know that if I put this person in my car, they will die. So let me call these guys. Sadly, those are really the drivers of why people call as of today. I think we'll get to a point where it's not, you're quarter to death, that's the only time you call. But for now,
Interesting. My second question was going to be about that USSD and SMS layer. I think because we don't want a solution that's heavily reliant on internet connectivity. Because, I mean, if it's an emergency, sometimes internet connectivity is disrupted, or, the landscape is that not everybody has access to the internet. But since we wrote that piece 4 years ago, the operating context of technology in Nigeria has shifted quite a bit. Mobile money platforms like OPay and PalmPay mean that people have moved millions onto digital rails, like penetrating even sectors that felt impenetrable into coming onto a smartphone. We've seen ride-hailing apps, dispatcher apps. People are used to, they're trained to know, I expect a vehicle to arrive once I put something in this app. So how has that kind of broader shift made your tech-enabled emergency response a more viable business model or product than maybe it was 4 years ago?
Yeah, I mean, I think you're absolutely right? Like, people are much more aware of the fact that this type of system exists and we apply it in other areas of our lives. So it's not so far-fetched to apply it in, emergency response. And I think that's why, at least I've observed, even in the last 2 years, pop-ups of different emergency apps, call. And I think that's great. It's a good thing. Fundamentally, if it increases access, win. But what I see is the constraint, and I don't know that enough of us are paying attention to that. You can't continue to layer an app off of infrastructure that doesn't exist or is declining.
Yeah.
And the way that I look at it is, and I think of like Uber or, any of these guys. Why did it work? Number one, when they started, they seeded their network, right? So I think they bought some cars and they put some drivers, like they had a way that they were like, okay, we need to get this going somehow, right? Yeah, like we need to start.
Yeah.
And then, network effects will eventually take over.
Yeah.
At no point has that seed happened in this space. What we have are many sort of layers and layers and layers, and everybody wants to layer, and new apps come and they reach out to us and say, we see people have a network, come, let's, and I'm like, well, we can try, but we know the sweat and blood, sweat and tears that we've put in to even try to get the network to where it is, and we're not satisfied with where it is, right? So anyway, I'm just saying, like, it's one of those things where, yes, we are in a place where it's more plausible, like people understand that better.
Yeah.
But because of the fundamental lack of infrastructure, I don't know that we are at the place where it's as simple as calling a Bolt or calling an Uber. We're not quite there yet. There's still a lot to get there.
The rails still need to be built.
Yeah, absolutely.
Yeah. So now I want us, and this is the section I'm actually most excited about. ERA has partnered with a lot of state governments to date, with River State, Ekiti State, Ogun State, Edo State. Each one of these looks different. Each one of these have varying levels of success. And I would love to just walk through them one at a time, just maybe quickly touching on points from each of the four. The first one is with River State. REMSAS. This was a more design and blueprint engagement, which I found very interesting because the River State Ministry of Health basically asked you to build a framework, to do some research and build a framework before the states procured a bunch of ambulances. And I think it's the inverse of what you typically see in terms of political instinct to let's just buy more ambulances, like just flood the market with ambulances. So my question for that one is more, you had to do that assessment. What did that assessment surface that the state had not identified, or what was surprising, what wasn't surprising? And I would just love you to talk through what you found in that assessment.
Yeah. So, I mean, first of all, let me say that everywhere we've worked, I have an immense amount of respect for the stakeholders that are leading their, ministries of health, the commissioners for health, the civil servants as well. I do genuinely believe that we have a lot of awesome people in healthcare. And that are really trying to actually like do things differently. So using Rivers as an example with the former Commissioner for Health, Dr. Adeze Ore, she was very keen on actually reviving what was a legacy for Rivers State. So Rivers was one of the states that actually did have a functioning emergency medical services system in the past. And unfortunately, just because, politics has a way of getting in the way of things, it got in the way of that. And so she knew that it wasn't that there was nothing, right? They weren't really starting from scratch. But rather than trying to replicate what had been done in the past or, just kind of build from the future, what would be the almost like theoretical basis for charting the way forward. And so that exercise for us was really a chance to look back and say, historically, what worked? What did the state learn? Where did things start to go wrong? How did they end up where they are? And can we, as we design the way forward, try to, put protective structures in place. But also what maybe needs to change or what is different about the times that we're in now, right? Technology being a key piece. And so that, project over a few months was really very insightful. I think that, it told us very clearly that when there is commitment, when there is political will, anything can happen. And it doesn't have to take a long time. But when it is not there, or when it is distracted or diffused by whatever, everything kind of goes wrong.
Yeah.
I think for me, the most surprising thing in that whole exercise was realizing that there were about, I can't remember the number now, it was either 12 or 21. I suspect it was 21, but don't quote me. But there was at least over a decade of data that just whoosh,
Disappear?
I don't know where it is. It was, let's just say it was not available.
Yeah.
And that was really painful because what it meant was, yeah, we want to build a framework, but we're now having to go off of whatever generic Nigeria level, broad healthcare sector level data is available, whereas you have a system that actually did work and actually did intervene and save lives, but that data was missing. So that one of the like most fundamental, sort of pieces to the framework that we designed was the importance of data collection at every stage, right?
Yeah.
So if we're doing a baseline, quantitative data, qualitative data. What are people saying? And we actually ended up publishing a piece out of that. So we did some of the qualitative research. We decided to pull it together and publish. And it didn't tell us what, to an extent we don't already know. What it did was really articulate it in the context of Rivers State.
Yeah.
And, by the time that engagement ended, and of course, politics and things happened.
Yeah.
But by the time that engagement ended, what the state was left with was a document that they could look at and say, if we want to set up a system, what are the things that we need to do? And, let's not go and lift what is happening in America and come and put it here, or what's happening in the UK and come and put it here. This document helps us to see what the role of community first responders are. And this is something that we are just very, very passionate about. Everywhere we go, we're harping on about community-based first responders.
Yeah.
Why? Because at the end of the day, as a country, we have many, many, many needs. Our money is limited and maybe not always distributed the way it ought to be distributed, which means that within the healthcare sector and specifically within emergency response, we're never going to have all the resources that we need. So how can we better use what is already available within the communities? And that, for us, is a key part of creating an effective system. And so what we basically proposed was, look, there are models already, Franco-German, like there are models of EMS already.
Yeah.
What you need to think about is how do we layer on the local context and integrate those things so that you have a system that works and meets the needs of the people, understands the local context, but is also cheaper to implement. Because whether we like it or not, resources are always going to be limited and the chances of sustainability go down when the system is very expensive. So that's kind of an overview of Rivers State.
I would then love to talk about the equity state or exams. What it's called? Exams. That was your first partnership, launched back in 2022. It didn't go so well. And I'm curious, what happened? What lessons did you learn from that experience?
Yeah, good question. So, I mean, again, a huge amount of respect for the Honorable Commissioner, Dr. Banji Fulani. I mean, truly, like what he's done within the healthcare sector there is incredible. And I think that in some ways we were early, right? I think that when we got there, the appetite was there, but there was so much else going on that I don't think that it got the, sort of full attention that it could have gotten, right? But I think what are the lessons that we learned from it? I think the first one for us was for us as an operator. We went in believing that we could provide some technology, some capacity building, and maybe some support here and there, and basically create a system. What we realized was that, and we've seen this now play out across multiple states that we've engaged with, more than 10 different states. Every state is at a different place in the spectrum of, functional EMS systems. So you have the states that have nothing. They never had anything. There's nothing, nothing.
Yeah.
Not even the ambulances are procured. Then you have the states that have the ambulances procured, but that's kind of it, right? So maybe it was a purchase and, there was a press release and, kind of, that kind of thing. And then you have the states that, like Lagos, that have actually a really, really functional system, but capacity is incredibly limited relative to the population and the needs and the available resources. So there's a whole spectrum.
Yeah.
And at the time, I don't think we were conscious enough of what that spectrum actually looked like. And what that spectrum means is that the level of support that you bring, the resources that you're bringing to that partnership will change depending on where they are on that spectrum.
Yeah.
And so Ekiti was really quite early in that spectrum at the time, right? Like I said, I feel like in hindsight, I think we were earlier than perhaps, it would have been ideal. And we didn't recognize that we couldn't just go in with, we have this technology. By the time we started, there had to be a recruiting exercise for the medical dispatchers.
Yeah.
Now, I think anybody will tell you that typically whenever there's recruitment that's happening with government, one of the things that you have to kind of be conscious of or protect against is, people will always want their people to have the opportunity. It's not a bad thing necessarily, right? Again, let's call it spade a spade. It's not necessarily a bad thing if the competencies required can be achieved.
Yeah.
That was not there, right? So that it automatically created a gap. So it's like trying to train somebody to be an emergency medical dispatcher that is not literate.
Yeah.
Where do you begin? How?
Yeah.
How? How? There's no magic. So I think that things like that really taught us that if we're approaching government, and that was always going to be part of our strategy, because one of our values, I think by now I've mentioned 3 out of 4 of our values, but one of our values is for everyone.
Yeah.
And it's the value that I always get pushed back on, because nothing is for everyone. You're a private business. You cannot be for everyone, and rightly so. But I think the way that we've approached it has said, look, we will serve the customers that can pay us. And for the ones that cannot pay, we will find the partnerships that make it possible for us to serve them.
Yeah.
Right? And so that's where, connecting with government and partnering with government comes into play. But anyway, just to say that in order to achieve that, we have to be able to adapt to where that particular government or state is at, and provide the right level of hands-on support or resources, whatever that looks like, that aligns with the stage they're at, which is why when we then went into Edo State, it was a very different transaction, very, very different. We were so much more hands-on. We came in essentially ready to handhold and do the work alongside the government, and all parts of the work, from recruiting to managing the team to fueling the ambulances to coordinating to staffing the command center with the dispatchers, training the every aspect of it we were involved. Why? Because we recognized that in this state we were also at the early stage, effectively starting from scratch. They had some ambulances, but that was it. And then going into Ogun State, we realized actually Ogun State is one of the states that has a pretty long history of delivering emergency services. And they try, again, simple lack of resources and all of that, right? But they do try.
Yeah.
So the need there was a bit different. What they needed was, look, in these particular areas, we're actually okay.
Yeah.
But our pregnant women are dying. And this, this was a particular area of interest for the Honorable Commissioner for Health, Dr. Tomi Koka, who is herself, an OB. And so for her, it was like, okay, this is something that I really want to see. I want Ogun State to be a model for supporting pregnant women. And because of that, we were able to, again, it's the same core principles, but tailor that to support and create a rural emergency transport system that now leverages what I talked about before, the community-based first responders, and now connects them into the state ambulance service. So now you have a system that if a woman is in a far-flung part of her village, but she's having an obstetric emergency, her community-based first responder can get her to, maybe the primary healthcare center, but maybe what she actually needs is, a CS, a cesarean section. And so they can get her from that point there, or if she needs to go to a hospital further away, the ambulance, can intersect. So it's a system that now works together, right? But it doesn't require every ambulance to be inside the village, but it really, sort of builds on everything. So I think we've learned a lot working across that spectrum of different needs. And I'm quite hopeful that we will do more with different states. We have a few in the pipeline.
So you basically touched on the other two I was going to touch on. So Edo State and Ogun State. I want us to, maybe we stay with Ogun State.
Okay.
Because this is kind of like that state level maternity and maternal mortality kind of addressing that challenge. I believe the number that's quite heavily quoted for Ogun State is 179 deaths per 100,000 live births. And one of the things I'm very curious about with this specific partnership was the voucher system that was tied to the Ogun State Health Insurance Agency. I'm very curious why vouchers specifically. And you could have built this as a maybe direct insurance reimbursement or similar to the Edo State model where that was tied very closely to the health insurance scheme. What made vouchers the right design choice? What was it about the women? And I think you started in the Odeda LGA. What made it the right choice for that specific program?
That's such a great question. I think vouchers served multiple purposes. One is just bringing tangibility to something that, again, we're trying to change behavior. If you think about what we're trying to achieve, we're saying that, hey, pregnant woman who's going to have a baby at some point, when you recognize XYZ signs or symptoms, we want you to take the following actions. And, how often do we interface with each and every pregnant woman? Maybe at most, if she's regular to her antenatal care appointments, between 4 and 8 times. I mean, 8 is like, whoa. But let's say 4 times at least in the course of her, pregnancy. That's not a lot. And when you're talking about changing ingrained behavior, again, don't forget, people are giving birth, with traditional birth attendants. People are giving birth in mission homes, these places run by religious institutions. People are giving birth all sorts of places, not necessarily always where is the best for their particular situation. And so I think the first thing that the vouchers did was it brought some tangibility. It said, hey, this is a service that is now available to you. It is free to you for this voucher. So it kind of made it seem like, you are paying for it, but you are not paying with your money. That voucher is giving you the access. Oh, yes, it was. Now, keep in mind again, right? We're talking about a rural emergency transport system. So we tried to design with simplicity in mind. The second thing that voucher did was it became an educational tool. Again, data, the value of data. And we partnered with a wonderful communications consultant for this. She does community engagement, Dr. Noemot Balogun. Somebody else you should have on this podcast. I strongly recommend.
Please take a note of that.
But we collected data when we started the project. And one of the questions that we asked was around, some of the questions we asked were around recognition of danger signs when a woman is pregnant. And I think we had, and I don't know why my mind is not remembering the exact numbers, but I think we had about 9 danger signs. And the only one that women consistently recognize, women, their caregivers, all of that, was bleeding. Fever was not considered thank you. It's normal, There were multiple other ones that you would think, but they were not recognized as danger signs. And so it became very obvious that, again, if we're trying to reduce maternal and newborn deaths from obstetric emergencies, if people don't know what constitutes an obstetric emergency, your ambulances will be sitting there waiting, right? So that voucher then became, again, in design, a tool for education. And so on the one hand, and I wish I thought I would have.
Yeah, I want to see what the voucher looks like.
Maybe we can send you what the design was.
Yeah, we'll stitch it on the episode. Yeah.
But on the one hand, it was this is what the voucher is. This is the number to call. On the other side, it was if you see, and again, right, with thinking design, who are these people? What will help them?
Yeah.
Images, pure images, not too much grammar.
Yeah.
So blood, you draw the drop of blood, pain, fatigue, like
Yeah.
you visualize it for them.
Yeah.
And what that did was it allowed women and their caregivers to recognize, what they would otherwise have missed.
Yeah.
And by the time we did our endline surveys, we collected data at the end of our pilot, because it was a very short pilot. It was about 4 or 5 months. By the time we collected data, there was a significant improvement across multiple measures, but also utilization of the system to get to care had gone way up.
Yeah.
And, because of the commissioner's foresight, for her, it was, I don't want you to just transport obstetric emergencies, also transport them to antenatal care. So now you have a system that is effectively a maternal health transport system.
Yeah.
Yes, emergency, but also just the antenatal care.
Yeah.
And what that actually did, and I think it's a brilliant thing to just do, especially at the rural level, is that it made it easy for them to get to antenatal care, which is where a lot of potential emergencies will be identified and caught and can be prevented.
Yeah.
But even in the event that they still have an emergency, because they have been in the habit of calling for that transportation, it is now part of their pregnancy journey. When the emergency happens, that's where they go.
know, yeah.
You're not trying to change behavior at the point of emergency, right?
Yeah.
So again, right, just thinking about, you asked about the voucher, but I think design broadly and how we design our programs and projects, it really has to make sense and meet the need of the moment. And again, I will forever give kudos to the leaders that are leading these ministries, because Dr. Kuka honestly really, I would say, led the charge.
Yeah. And that's what happens when your Commissioner for Health is an OB and is thinking about these things.
Absolutely.
So kudos to Dr. Tomi Koka. I don't know if we're related. We have the same last name. And
do.
I'm also from Ogun State.
You probably
I
are.
will need to investigate and maybe have her on.
Okay.
But yeah, that's amazing. And I think I want to then go to the Edo State program. It's the one I want to kind of really dive into because, well, I'm from Edo State on my mom's side, so I'm part Bini. But in 2024, March 2024, that was when it was launched. But it has the connection to the state's insurance scheme, so the Edo HIS, directly into the emergency response system as well. So that one, I'm curious to understand, how were you able to stitch those things together and how did that kind of play out?
Yeah. So I think the first thing was kind of recognizing that we don't like to do projects that start and stop. In other words, we start, the nature of a project is that it starts and stops, right? But ideally, we want to be the catalyst for a system existing. That's the goal. And so what that means practically is we come in with our inputs, our expertise. In some cases, maybe we have a development partner that is bringing some funding and the government is putting in some funding as well. And we help to start. And then ideally it gets carried. And so we recognize that for that to happen, the sustainability part, it was important that the system was tied into an existing payment mechanism within the state. State insurance schemes and insurance schemes generally, I guess by policy or by law, they're supposed to have almost like an emergency fund, like a thing that, covers for the unexpected, right? Which is inevitable in healthcare. And so, with all of those things in mind, it was really important that we designed from the beginning. And so we had the privilege of having some of the key leaders in charge of the Primary Healthcare Development Agency at the time, in charge of the Health Insurance Agency at the time, really work with us to put that design together. And, there were just some really great key people that were, facilitated that conversation and that design process. But what it basically meant was even within our technology, because our technology then went from being a solution that only we use to almost being like an enterprise level software that we can provision for a state.
Yeah.
And so Edo had their own version of our dispatch application, all of that. Yes. And what we could do was we actually integrated that into the health insurance scheme. And so it meant that when somebody calls, we can check that phone number against the database of enrollees and know immediately whether the caller is enrolled. Now, a lot of times, right, people are calling for other people.
Yeah.
So the fact that they are not enrolled may or may not mean much, but at least it's a first check.
Yeah.
And then by the time we recognize, okay, if maybe you're calling for somebody else, there might be other parameters that we can check against. But what it meant was we could identify who we could transport to certain types of hospitals and how it would be paid for.
Yeah.
Keep in mind that I said at the beginning that one of the biggest problems is the issue of paid demand, right? Like whether we like it or not, healthcare must be paid for somehow. Whether you're even going to a public hospital or you're going to a private hospital, doesn't matter, it must get paid for. And so having that system that integrated with the health insurance scheme meant that it was easier to identify how patients would be paid for.
Yeah.
And that was helpful from the hospital's perspective, the receiving hospitals, because it meant that, you're not going to bring me a patient that, again, out of the goodness of my heart, I will treat, but then, I'm going to be stuck with the bill and I'll have no way of recovering. Long term, the objective was that as the insurance scheme collects premiums, a portion of that premium is set aside to support the sustainability of the EMS system.
Yeah.
And when I think about what does it take, I know you mentioned like scale, right? Like what does it take to scale emergency services and to fund them in a way that is actually meaningful?
Yeah.
It's not going to come from somebody waking up someday, maybe Bill Gates, I don't know, and giving us a giant pot of money. You can remove that part if you want. I don't know. It's not going to come from that.
Yeah.
Like that's great, but those funds again are meant to catalyze.
Yeah.
So what is the sustainable path?
Yeah.
Whatever it is that we are already collecting money for, whether it be insurance, whether it be taxes, whatever, we should, if we have the mindset, we should be thinking about how does a portion of this fund the continuation of this EMS system.
Yeah.
So that whether the service is being provided by government or by the private sector or by the hospital, doesn't matter. It is taken care of.
Yeah.
And the incentive is there for those services to be to continue to be provided. The trust is there for the public to continue to call.
Yeah.
And the benefits to the healthcare system broadly and the economy broadly are huge. I was going to say when you talked about Anthony Joshua, I think sometimes we forget that if, and God forbid, truly like rest in peace to his friends that did pass, if he had passed, think about not just like the social horror of it, but the economic impact. How many livelihoods were tied to the work that he did?
Yeah.
And again, we can only process that because he's such a global star.
Yeah.
But every person that dies in an emergency is in themselves an institution of whose
unit.
other people's economic livelihoods are tied to, right? So again, yes, we need the sustainability of the system, but I think we also forget that if you sustain that system, it will also put back more into the economy than what we're actually spending on it if we design it right.
Yeah, yeah. And that beautifully leads to our question that we ask everyone.
Okay.
The cure question. What does it take to revolutionize the African healthcare business model, specifically in your world of EMS? You've touched on it just now with that response.
Yeah.
But, as we said, EMS in Nigeria has existed for decades. It's been fragmented. It's concentrated in big cities, operating without the necessary financing. And maybe the regulation is there or still needs to evolve. But what does it actually take to move emergency response from a service that 3% or 1.8% of Nigerians use into that layer that sits underneath all kind of health reform, and we almost, how do we flip the script from 3% using and 95% not using to 95% using and maybe 3% not using?
I don't know if my answer is going to be like very likable. And then what I mean by that is I've been told that, you see this thing too emotionally, you're too like passionate about it, and rightly so. It's cool. I am okay with that. But I think it boils down to ownership and responsibility, right? That sense of, if we like, we don't have to do it. All of us are affected in one form or another.
Yeah.
Eventually everybody gets touched in some way, even if all you do is observe a situation that you are helpless in. I think that ownership looks different for different people, right? So let's say, I don't know, maybe you're a bank. There are ways in which you can think about, how do I offer this to my stakeholders, my staff, my account holders, whatever. But maybe maybe I have CSR funding and I say, you know what, actually it's true. Let's, contribute, maybe add to the pool of ambulances or add to the trained pool or, whatever. You're a bank. Nobody's going to ask you to leave banking and come and do EMS work. I can tell you it's not as lucrative. Yeah. Please stay in the bank, but there's something you can do, right? As individuals, the same is true. As government, the same is true. And I think that to the extent that we are ready to truly take ownership at scale, then we can start to see things change at scale, right? Yeah. So I talked about the insurance scheme and, trying to, ensure that a portion of those premiums are being set aside. We have a few of those types of models, some of which we've already implemented with some partners, some of which we're exploring with new partners in new industries. I'm a big believer that the funding for this system isn't going to come from the sources that we expect. Yeah. It's not going to be from the standard, hospitals or HMOs. Like they're trying, they're doing what they're supposed to be doing. They're there. But what about everybody else? Everybody else who benefits when the system works. Yeah. Everybody else who loses when the system doesn't work. What role can each of them play? So I have my thoughts and opinions, but I think like fundamentally it boils down to a determination that while I may not be in this industry, it is not somebody else's responsibility to fix it because it affects me. Think about why do people buy fire truck these days? Estate will buy fire truck, bank will buy fire. True. Why? Because they know if there's a fire, you are on your own. Yeah. Now, don't get me wrong. Again, Lagos State really does try. There are places that we have some. Yeah. But it's nowhere near enough to meet the need. Yeah. And so we've learned as a people to be self-organizing. One of our advisors at ERA wrote a book about self-organizing Nigeria. And we've learned as a people to do that. But I think self-organizing needs to move from, I'm just going to handle my own little piece of the pie, to how do I contribute to a bigger, broader reality that actually leads to systemic change. Yeah. That part we haven't quite figured out. I think we want to be part of catalyzing that change, but it's a lot of work.
Yeah, it is. And I guess a question I have to wrap up our Cure question section. What does an African-led, African-financed, and African-operated version of this revolution look like to revolutionize this business model in the way you've just described? And what would need to be true for it to happen in your lifetime as an operator?
Africa-led, African-financed,
African-operated.
African-operated. The led and operated, I think, is straightforward, right? Me, I'm African. My co-founder is African. She's from Ghana. Pretty much our entire team is African. Yeah. So that piece is straightforward. And I think it's true of many organizations. Yeah. I do think that what happens as we grow and mature and scale is that we start to recognize that there is also a local talent gap in terms of higher levels of management, higher executive levels, right? Yeah. And I think there's been some recent controversy, which I'm not gonna
we will
point
not get
to
into,
that.
But you can find it if you want.
Yeah, exactly. Yeah. So I think that becomes more of an issue as you start to sort of get to certain levels and places, right? Africa finance, that's the kicker, right? Like that's the hard one, because I think that any company that has raised, and I want to be clear because I recognize that there's a bit of a difference between, in quotes, this our modern startup sphere versus like more traditional businesses that have existed for decades. But I would say, like, specifically referring to this more recent startup phenomenon, a lot of the funding is foreign.
It is.
And it's foreign for different reasons. One is, there are people that are very optimistic about Africa and they see the opportunity to make good money and they think that there's a lot of raw material here. And if they invest early, they can, and there's good truth and true, makes sense.
Yeah.
There are a lot of people who have, more philanthropic capital that see a huge opportunity for impact and want to be able to, sort of be part of that impact story and will fund because of that. And all important, all useful. We have certainly needed and benefited from both types of capital. Local capital is harder to come by. Like debt capital, for example, unless you have your Banana Island property or similar to offer up as collateral. They don't take children, apparently. I'm kidding. I did not offer my child. But you get what I mean, right? Like, unless you have that, it isn't easy to get debt capital. And again, right, I understand some systems were not really designed to, sort of take the level of risk that is there. There has been a lot more in terms of like angel investing. People are putting their money out there more. But again, when you have an economic challenge, it means that people will hold on more tightly. What they expect or what they demand is also maybe not unreasonable, but is also just, higher and makes it more difficult. And so when you think about, African companies that are innovating, they are, in quote, competing with the companies in environments where the capital available is very much risk capital. It's very much, hey, I like what you're doing. I'm going to make a bet. And I am fully aware that this bet may not work. Which is why I'm making many bets, but I'm going to give you enough to truly make a go of it. And I know it's certainly been our experience where you have what feels or seems to be a lot, but when it comes down to, you realize that you have enough to survive. And enough to kind of keep going and experiment here and there, but never enough to take the big bets to really sort of go all out and, if it works, it's psh. If it doesn't work, well, you failed, right? No, you experiment small and you say it must work, you know? So it's a very different environment. Do I have a solution? I don't have a solution. We need more capital, sure. We need more local capital, sure. What is going to be the trigger that gets that to happen? I'm not sure. Maybe it's about thinking about the pools of funds that we have sitting that we don't necessarily want to like throw away and kind of risk anyhow. But maybe there's a way to leverage some of that philanthropic capital to de-risk some of, I think there's things that are happening. But honestly, I don't have an answer. I just know that there is a challenge when it comes to local, like African-led financing.
And it's interesting. Someone shared, I think it was Sugar yesterday or 2 days ago, an article, a Substack article about the middle. And basically, and I'm going to terribly summarize, but the thesis of the Substack article was there's the startups in the very beginning that people are taking these bets on. Like you have this vision and it's like, whoa. So your Series A, your pre-series, all of that, you get a bunch of investments. And then you have your more mature companies that have shown, look,
track record.
We have a track record. We have scaled. We are doing the thing, and people are investing in that because it's
a sure, almost like a sure
it's
thing.
It's a sure bet.
Yeah.
And then you have the middle where it's like we have enough to get by. We've shown our track record is there. It's not at scale yet. We need that money to scale. But that money is either going to people who are 10 years behind us
Yeah.
or 10 years ahead of us.
Yeah.
And we're in this middle where it's like, and to me, I'm like, when I was hearing you talk, that Substack article kind of came to mind. I have to remember who the author was. But that's kind of where the capital, whether it comes from VC, whether it comes from, debt capital, private equity, whether it comes from government pools, that middle
That's where
ground
it's needed.
is
Absolutely.
where it's needed.
Absolutely.
Yeah.
Because there's only so much impact a small, but what pre-seed, I don't know. There are people that raise like 20 million pre-seed these days. So I don't even know if those stages mean anything. But, when you're small, your results usually are small.
Yeah.
Right? And your impact usually it matches the scale of where you're at. When you are huge, again, right? Your impact and results usually match that scale. So it is in our best interest to have at least a decent number of companies make that transition. Yeah. Rather than continually be top heavy. Yeah. And then only a couple, sort of manage through. I would definitely say we're in that middle right now, right? Enough to show that, look, we know what we're doing. Yeah. We don't have it all together because who does? Yeah. But we've done enough to warrant, a measure of confidence. Yeah. But we're not at scale. There are multiple sort of hurdles that we still need to jump to get to scale. Yeah. Who funds that? Right? And I think, so this is now maybe some of how my thinking has evolved over the last few years. There's, there was kind of the growth at all costs mindset, right? All you're thinking is top line. All you're thinking is getting funding to grow that top line. Yeah. Very little attention to the bottom line, right? And I think many of us in this space have been like, yeah, that works if like Silicon Valley is throwing money your way. Yeah. If not, on your own, sooner rather than later. And so definitely like my thinking has evolved to be like, where's the bottom line? How do we show that we're profitable so that, right? If I get external funding, I know that I'm using it to scale what works or, create new opportunities or invest in new assets, whatever that looks like for us. But if I don't, I am still here. Yeah. Right? My staff are still working. They're still getting paid. People's lives are still being saved. Yeah. We're still, it may not be the impact we want at scale, but we're still here and we can last. Yeah. Right? And I think that is the shift that I've definitely made. Yeah. And that's top priority for us is just, look, let's be sustainable as an entity. When we are sustainable as an entity, then you have a really strong foundation to start saying, okay, let's scale this, let's scale that. I talked about the vision, training, academy and all that. Great. Yeah. It will come. Yeah. But I want to build it on a solid foundation, right? And I think that's where many of us have to get to and are already thinking in that direction for sure. Yeah.
So we want to conclude our discussion today looking ahead to the future. Okay. I want to spend, this final stretch specifically on your long-term vision for ERA. Okay. And where you see the company going. The name of the company is Emergency Response Africa, not Emergency Response Nigeria. So from the beginning, that vision has been Pan-African, continental. You mentioned your co-founder is Ghanaian. The two of you have spoken about the problem being Pan-African from day one. Where does that vision stand today? Like, what does the expansion plan beyond Nigeria or even to multiple states within Nigeria, because there's still expansion needed within the country. What does that look like? I mean, I feel like you've already said it or you've already touched on it. Yeah. Absolutely. The vision was always Africa. I have some really good friends in, Uganda, just like other parts of the continent. Yeah. And I'm not sure there's any African that I've spoken to
in any depth about what we do, that's like, oh my gosh, you have to come to my country.
Yeah.
Because we have the same problem, right? And if you go and dig deeper, similar to Nigeria, it's not that these countries have nothing. Of course, you have the ones that really do have quite robust systems. South Africa, Kenya, Egypt, like they're kind of the usual suspects.
Yeah.
But most countries are similar to Nigeria. You have pockets of hope.
Yeah.
And then, areas of darkness and, just it's different.
Yeah.
And so I think for us, we see ourselves as still in that phase of defining what becomes the model that makes it possible to be Emergency Response Africa.
Yeah.
If I go tomorrow, let's say Uganda is like, hey, we love what you guys are doing, come.
Yeah.
I have a sense of what we would do, right? I have a sense of what the partnerships are that we would need and, all of those details. But we didn't know that until we started in Nigeria, until we've, had different engagements with different governments, until we haven't really talked a lot about private sector in this conversation, but, until we've learned who our customers are within the private sector, who are the folks that prioritize health and safety and pay for it.
Yeah.
And those that are like, Jesus is my protection. And it's true. Those are the realities.
Yeah.
And so, yes, I think the long-term vision is to establish an organization that works in all the countries across Africa. I think we're clear that we want to be able to work with local leadership. Now, whether that means that, everything is sort of centralized and you're pushing out, or whether that means, kind of those are details kind of to be figured out. But I think Ghana is like a very next obvious market. We have a couple of team members based in Ghana, in addition to Mami being from Ghana. So that's the big picture. But the truth is, Nigeria is huge. We haven't even begun to scratch the surface. So there's still a lot of work to do here. But I'm hopeful that within a few years, we should be in a position to actively be expanding into other African markets.
Yeah. And I remember explicitly looking at the NHIS from Ghana, and they explicitly mentioned that all emergency services are covered. So Ghana has that
policy framework
in place that could be leveraged for a potential expansion. I'm very curious, which across the continent, you've mentioned a few countries, which markets do you think are the most ready for what ERA has built? And which would you rule out for now? Or maybe let's focus on the ones you see are most ready specifically for what your company is building.
So I think because our approach has always been, and I think will continue to be, a hybrid of both private and public sector driven in terms of where our revenue comes from. The markets have to be able to support, first and foremost, the private sector business. And then have a pathway into public sector partnership or public-private partnership. I can't, I don't have set countries. A list of countries as of right now. But I think what's very obvious to me is that, the countries where, the health and safety needs are clear and evident based off of the industries that are like dominating their economy, make for an obvious, sort of direction to go. But again, just because of the nature of the business, I would always pair that with, do we have an active relationship that can get us into a partnership with government so that we're coming in and we're able to serve both those who need it and can afford to pay for it, and those who can't. And we can still sort of fulfill our vision and our mission.
And then my last question, if a functioning EMS system actually existed across Nigeria and the rest of the continent, what does it unlock in the wider health system? Like, what opportunities does it open? What bottlenecks does it, suddenly start to solve? I'm very curious from your perspective.
So many things. And I think we've touched on them in the course of the conversation. I think first and foremost, you mentioned that, it's very much an equalizer, right?
Yeah.
Like we joked that if you're holding 10 million naira in your hand and you get into an accident, like that's not necessarily going to mean that you survive.
Yeah.
The system that affects, the really poor person also affects the really rich person. And so I think like what would life look like? First of all, just people would access the healthcare system better.
Yeah.
What it means is that when they show up at the hospital, they're not showing up so late that 75% of them are either dead on arrival or dead within 6 hours. That's a crazy number.
Yeah.
It tells you that it's not that the hospital was not ready to work. It's that they arrived so late that intervention really could not be meaningful.
Yeah.
So I think that's one. But what it also means is that for the healthcare workers, they will see the fruits of their labor more. It's like you're intervening and every patient is dying. Almost 3 out of 4 patients are dying. Not because you don't know what you're doing, not because you're not capable, but because, again, the system has failed them. So you can imagine the knock-on effects for a healthcare worker who is seeing the value in what they're doing and actually making a difference, right? We're not even talking about funding and all that, which are big issues as well. I think what it also means is economically, right? We talked about how each person is a unit, an economic unit, who have other people and their economic livelihoods tied to them. Imagine saving the life of, a father who's a breadwinner of their family in the village, right? So you've literally gone from one situation or one possible outcome where the person actually died and the family was thrown into generational poverty to one where actually he's able to be alive and continue to work and all of that. Or maybe it's the mom and she's the breadwinner, whatever.
Yeah.
In other cases, and there's, research that shows that when a mom dies in childbirth or, during pregnancy, the child's educational attainment plummets. And we know that educational attainment is also tied to poverty and generational poverty, right? So again, these are sort of the long tail effects that are really quite hard to trace, But again, if you have the system functioning, not only does it help the healthcare system itself, it helps the economy as a whole. And if you think about what do developing countries want more than anything? They want foreign investment, right? They want people to come and do business in their country. They want people to come and boost the economy, pay taxes, all of that. What makes it possible for those companies to come? They need to know that not only can they do their business and get the value that they intend to get, but that they can do it safely. Why do countries in conflict suffer so much? It's not just because they don't have the resources or whatever. It's because the safety aspect is missing. And once it's missing, the economic inflows that would have come disappear. And whether we like it or not, as Nigerians, we also have to acknowledge that has played a role in the decisions that a lot of companies have made. Why will I bring somebody from where they're chilling in, wherever, access to 911, great, hospitals, all that. We too, we have great hospitals. We have those things. But when, again, the system, the bridge is broken, it means that all it takes is one incident and everything scatters, right? So I think, for me, I think of it from the lens of not just what it does for the healthcare system, reducing the cost of care and, increasing the satisfaction of the people that are working, but also economically, right? Like, if we get it right, it will have a huge effect, but then we'll eventually forget about it. Why? Because it will become part of, a functioning society. And it will be one of those things that we will eventually take for granted. The way an American typically would take 911 for granted, right? So, yeah.
All right. So we've covered a lot today, but I think it's been a fantastic conversation.
Great.
We want to conclude with our rapid fire.
Okay.
So like I said, rapid fire, we ask quick questions, quick responses. We'll go through a couple. Where do I start? One global EMS model more African systems should study.
That is such a good question. Can I reference an Israeli organization that we actually studied.
Yeah.
I know there's a lot going on, in that part of the world.
Yeah.
But United Hatzalah or United Rescue, as it's called in English, they have created a phenomenal system that I think speaks to what a community-based emergency medical services should be. It is volunteer-driven, volunteer-run. These are literally people that live and work in other professions. They go through about 6 months of training to become basically EMTs.
Yeah.
They get equipped with these motorcycles. They have like their jump bags and everything. And they have 90-second response times.
What?
Let that sink in for a moment. And my co-founder and I, we had the privilege of actually going to Jerusalem, their headquarters. This was back in 2019, I think. And actually just like observing. And man, my mind was blown.
Wow.
They're not doing it. Listen, it's not complicated.
Yeah.
We're not talking like deep tech.
Yeah.
We're talking simple, efficient coordination, heart-driven work. So these are people who literally lay their lives on the line. Keep in mind, there's a lot of conflict in these areas too, right?
Yeah.
But they go in and they intervene, whether they're Christian or Muslim or Jewish, they all go in and they intervene for their fellow man. Like that's how they operate. And I think, it gave us a lot of inspiration as to what an effective system could look like. In fact, they were so effective that by the time the government said, okay, we have our own ambulance system, they had to work with them.
Yeah.
They had to, because that's where trust was. That's what people wanted. That's who they called. Why? They actually played a live call for us. 90 seconds.
Wow.
Somebody was at the scene of it. I think it was like a choking child. Like, imagine that.
Yeah.
And we're talking about 25. We see 25, 35 minutes too. Why?
Yeah.
Because things are hard. There's a lot of things to coordinate.
Yeah.
So best case, maybe we'll get like 10 minutes. But like sometimes it's 20, it's 30, it's 50, depending on, a lot of factors. But this 90 seconds? Come on.
Is
so
crazy.
That would be my pick.
Yeah. Fantastic pick. The most surprising thing you've learned from inside the command center?
People want hope when they call. Yes, they want help.
Yeah.
Right? But what upsets them the most is if they feel like they called for help and they're not going to get it. Not because it's taking you too long to come. I mean, that could be part of it, but because of the communication. And so, like I said about, our values and empathy being one of our values, we talk about how even the way you speak, one of the behaviors under that value is our very presence should bring hope.
Yeah.
So that means that once you pick up the phone and you call, in talking to a dispatcher, you feel like, okay, I'm talking to somebody who can actually help me.
Yeah.
And as the conversation progresses, your confidence in that should grow.
Yeah.
I think for me, it's been really interesting to see that, they want the physical help, but sometimes it's just that reassurance, that sense of you're not alone in this.
Yeah.
We will figure it out together.
Yeah.
Oh.
One piece of advice for a young founder building, well, it doesn't have to be a young founder, an early stage founder, building in a category that is barely on the map.
I love that. Barely on the map is such a good way to describe it. I think prepare for the long haul. So if someone had told me that 7 years later, I want to quickly say that my daughter is 7 years old.
Oh, wow, okay.
When the Jerusalem trip that I mentioned, she was literally on, I was carrying her the whole trip.
Oh, wow.
She went with me everywhere. And so literally been building this, like I say, this is her big, I don't know whether it's a boy or a girl, whatever, right? This is her sibling.
Yeah.
Just prepare for the long haul, right? I think, and this, I'll share this. There's a guy that I love very much. That this sounds so awkward. He's an author that I love.
Yes, I was gonna say,
my husband. And he wrote, a couple of great books, but he referred to one book that I guess he read. I think it's called something Systems. Can't remember the name now. Beautiful. And he quoted this in a talk that he gave here in Lagos at one point. And the quote basically says something along the lines of, if you understand the rate of change of systems, you wouldn't give up too quickly. Something along those lines.
Yeah.
And that came at a time where, honestly, I was ready to give up. I was tired.
Yeah.
And it's because I, at the time, didn't realize that I was doing systems building work.
Yeah.
I was just trying to run a business. I was trying to deploy technology.
You didn't realize you were building the rails.
And so anyone who's coming into something where you are building a system, there are things that can move quickly.
Yeah.
But things never move quickly until certain foundational things have been laid.
Yeah.
And so prepare for the long haul. Recognize that there's a certain rate at which systems change.
Yeah.
And no matter how magical you are, that rate will be maintained. And so your only job is to keep doing what you need to be doing and basically survive long enough for that system to change.
Yeah. And my last rapid fire question, we ask all of our guests, what gives you the most hope today?
I think one is that we're still here. We could have died a few times. I can tell you with confidence. And maybe this is part of being a faith-driven entrepreneur, knowing that at just the right time, help comes.
Yeah.
That's one. I think the other one is I'm seeing conversation happening today that was not even like a thought, 4 years ago, 5 years ago. Some of it we, might still feel like, is it really what it's supposed to be? But the things that people are even using to, in quote, flex politically now are different, right? They are positive for the emergency services space.
Yeah.
So I think that change is happening, right? Again, it's a system. So change is happening very, very slowly.
Yeah.
But it gives me hope that at some point we will have in, the right position of power, a person for whom this is a priority.
Yeah.
And that if hopefully they are an effective thinker and systems thinker and designer, they will put in place the things that will open the doors and create a functional but also sustainable system.
Yeah.
So like I said, I'm an optimist.
Yeah.
I remain hopeful.
Love it.
And let's see what the next few years holds.
Yeah, we love having optimists on our show. Folake, thank you for sharing your work, your conviction, and for showing us what it takes to build in a service category that in a country that has needed it for a very long time. I think for me, the takeaway is trust needs to be built. And the building of that trust looks different from what I came into this conversation thinking. The question now is whether the rest of the system, public, private, federal, state, can build that same standard and speed of service and reliable, trustworthy service that the Nigerians actually need. Yeah. So for our listeners, you can follow Emergency Response Africa to see the work that they are doing. They have a lot of case studies on their website, which formed a big chunk of the conversation today. And if you remember nothing else from this episode, remember the numbers. 112 is Nigeria's national emergency line. You said there's a Lagos line,
767.
767.
And different states have different numbers.
Different states have different numbers, but this is being recorded in Lagos. So 767 if you are a Lagosian. And 0802255 is ERA's 24/7 toll-free line. Doesn't roll off the tongue as much, but it's there. It's 24/7 and it's toll-free. Save them both. Save all three of them. 112, 767.
And ERA's number.
ERA's number, which you can just rewind a few seconds back, and tell someone about them. And don't forget to subscribe to The Cure and TC Health. Wherever you get your podcast, wherever you get your insights, we're on Substack at tchealth.substack.com. And share this episode with anyone who cares about building the rails that make healthcare innovation possible in Africa. See you in our next episode. Bye. Do you want to say bye?
Bye.
Bye.
Thank you.
Thank you.